Hello, hello. Welcome in, everyone. It is officially 11:30 Central Time, so we're going to go ahead and jump right into our webinar covering everything you need to know about geriatrics today, because I promise you there is a lot of content to go through, and I run over every single time I give this webinar. So we're going to jump right in on it. I know that the Instagram Live's not working, and I put the link up there for those of you on Zoom who are jumping in from Instagram, welcome in. This should work the same, and the benefit is now you get a CE credit, 1 hour for coming to the Zoom rather than the Instagram Live. So welcome in, everyone. My name is Annalise Caffrey. I am a doctoral family nurse practitioner. My specialties, of course, are geriatrics and preventative care. I love talking about diabetes. I love talking about hypertension. I love it all. So that is all the good stuff. Before we jump right into the webinar, just wanted to introduce myself a little bit. And I will just address the elephant in the room. I do look a little funny today. Usually I look more attractive for you guys for these webinars, but I ran into a door. I was on a family reunion trip this weekend, and we made it through the whole reunion. No one got injured, and it was about midnight, and I really had to pee. I got up and I ran right into a door. So my eye is a little swollen, and it's just glued together with some steri strips there. So it's not my best webinar look, but I thought it does really tie into geriatrics very well, because we're going to talk about fall prevention today and home safety, which would be a light on in the bathroom for when they have to wake up in the middle of the night. So without further ado, we will start here just with our disclosures. Quick disclaimer slide. We don't have any financial interests here, no shady deals with a calcium supplement company or anything. This is really just, it's good evidence-based info. I have a major love for our older adults, our aging community, and I promise I'm going to go really fast for this. I'm going to keep it relevant, and hopefully it's a little fun for you guys and you get some information. If you are joining here through Zoom and you stay for the full hour, you are going to get one contact hour that can be used. Some schools accept them for coursework stuff. My school took them as extra credit, so you can always ask there. But also, if you already are a family nurse practitioner, these can be used towards your credit hours that you need to recertify. So stay here. Don't sneak off to check your DoorDash order. We're going to cover a lot of information. On to our learning objectives. This is kind of just our big game plan. First, we're going to break down how aging changes the body, because I think that's really important. So you need to know what changes in them and how geriatric syndromes kind of show up, because they are going to be tested on your boards. And then we want to nail down things like meds, chronic illnesses, diseases, falls, of course, fall prevention. And I just want you guys to really think of this webinar here as your clinical cheat sheet. It's clinical cheat sheet meets exam survival guide. So, what are you going to see in clinic, and what might you be tested on, and how does that meet each other, and how can you provide safe care for an older adult population? Because I want you guys to remember that in the United States, the older adult population is huge, and it's growing because we're coming up with more ways to help people have better quality of life and live longer. And so we need to know the geriatric population. So before we jump too much into actual content, I want to introduce you guys to Slido today. If you guys have been in webinars with me or with other people before, this will feel familiar. If not, what you guys are going to do is you're going to take out your phones and scan the QR code. That's going to take you right to the webpage. If you are watching this webinar on your phone and you need to like switch sites, you can just literally type in slido.com. That's going to take you to Gero, to the slido.com, and then you're just going to type in Gero number 4 NP. You don't have to put the hashtag because it is already there, the hashtag. So all you need to put in there is just the Gero 4 NP, but the QR code will launch you right in there. So we'll switch over here to my Slido right now, and I will get that started for you guys. I'll give you just a couple moments to join. I know sometimes that takes a little bit switching back and forth between screens. So join here, and I want to know where you are in your NP journey. So are you a student, graduated, you're already practicing, you're in your first semester, you're in your last semester, you are studying for your boards? Where are you guys at in your journey? Comment in there and let me know. Studying and scared. Studying for boards, 1 semester to go, last semester, studying for boards. Guys, that is awesome. I'm really proud of you guys. I give this caveat at the beginning of every single one of my webinars because I think it's really important that you guys recognize this, especially since it seems like the majority of you guys are currently studying for your boards, prep for boards, or in your last couple semesters of school. Boards are not meant to be something to stop people from becoming a nurse practitioner or stop someone from being able to practice. And I feel very strongly about that because I get a lot of repeat test takers that I tutor or that I'm working with. We do private tutoring at Archer, and that's something I'll talk a little bit about more if you feel like you need more one-on-one help. But I work with a lot of these repeat test takers and they feel like failures. And I totally get it because I would have been exactly the same. I was so nervous before I took my boards. My family was like, "You're a stress case. We don't want to hang around you." Because I was really nervous. And the boards are just a way to make sure that you know some of the information that they want you to know. If you have graduated, if you've even made it to your last semester of NP school, guys, I did NP school. I know how hard it is and how much work it takes. So if you made it that far, you are more than qualified to be a nurse practitioner. And this is just a test you have to pass. And that's the way I like to think about it. Okay, moving on to our next question. Where are people joining from? Let me know in the comments where you're coming from. We'll see if we have anyone from my state. North Carolina, the Philippines, Tennessee, Washington, Arizona, Utah. I actually, funny thing is, I am from Arizona and I currently live in Utah. So we've got a couple of you guys out there that fit in there. Puerto Rico, I have been to Puerto Rico once before with my family on a trip there, and it is beautiful. And I had some of the best orange juice and pina coladas I've ever had in my life. I think they say that the pina colada was invented in Puerto Rico. Philippines, is your guys' weather just hot, hot, hot right now? Arizona, I know, is up past the hundreds already. North Carolina is getting pretty humid. There we go. Humided. I'm inventing new words. Okay, guys, we've got a good little group here joining from all around. I love to see that. Okay, and then last question we're gonna ask before we jump in. I just want to know how confident you guys feel. This gives me a really good gauge of how much you guys get out of my content, because I know there's a lot of complexities to caring for geriatric patients. So I want to know how comfortable you guys feel and where you're at there before we get started. So I know, like, okay, I can breeze over some of these subjects or no, they need a lot of help. A 6 is actually a really good score, guys. This is probably one of the best ones I've seen giving this geriatric webinar. I'm glad that you guys feel that level of confidence. That makes me feel really good. So I love to see that. Okay. Well, our next poll is, I'm pretty sure, just the question as we get started. Yep. Okay. So back to our webinar. Okay, this slide is just a reminder that geriatrics is board gold. So we're going to dive into this just a little bit more, but you really can't ignore this content because it's like up to 25 to 30% of the boards right now. Whether you're acute geriatric NP or whether you're FNP is about older adults. So you really need to learn it, lean into this and kind of learn those important points because I can't tell you what test questions you're going to get, but I can tell you that up to 30% of your test can be about older adults. So it clearly is a subject that needs to be studied. So this is my geriatric greatest hits list. That's what I like to call this. This is this one at the next page. Screenshot these, guys. I made this to be screenshotted. You're not stealing information. This is what I want you guys to know and to memorize. This is the high yield list of stuff that is highly testable and highly seen in clinic. So it's not just about passing boards, because remember, that's just an easy breezy test you're going to take. But after that, I want you guys to feel confident caring for older adults, because whether you're in acute care, family practice, unless you're in pediatrics, you guys are going to see a ton of geriatric clients all the time and a ton of geriatric disorders like cognitive disorders, polypharmacy, falls, chronic illnesses, how to spot a UTI and how UTI show up as confusion. So this is all stuff you want to know. We're even going to talk about ethical pearls, some tricky stuff like sleep and incontinence scenarios. This is really your roadmap. So if you know this slide, plan for it to possibly be on your boards, because it could be. This is all highly testable. So the better you know this information, the less the less you're going to feel caught off guard when that test actually happens. So there's this slide. This is all really good stuff. And then one more slide for you guys. With the content. All of a sudden, I don't know how to switch slides. There we go. Two more: geriatric syndromes, ethics, and safety. So remember, just one last time, 20 to 30% of your board. So that's important to know. Moving on to geriatric changes, I want to touch a little bit about what changes in the body so that you understand why we treat older adults differently, because we do. We don't treat an older adult the same we do as a pediatric patient, as a kid, or just as we do a middle-aged adult, as they would treat me. So you're treating an 80-year-old and their normal is not going to be the same as your 40-year-old uncle's normal. So we need to break it down body system by body system and look at kind of what changes, what's normal, what's abnormal. First thing I want you guys to know is cardiovascular changes. Older adults, they have stiffer vessels and lower muscle mass. That is normal. And if you think about that, so if they have stiffer vessels, we know that their cardiac output declines a little bit. What can you expect? You can expect that blood pressure meds work a little slower and that one glass of wine is going to hit them differently. This is going to affect all of their blood pressure, all of their cardiovascular output. And then also with those body composition changes, it's going to affect how they metabolize everything that we give them. They have less body water, so that affects drug distribution. They have increased body fat. That's going to affect drug distribution. And then they have decreased muscle mass. Those are all really, really important changes in a geriatric population that I need you guys to remember. Because if you can understand that they're different and their bodies are different, when they respond differently to medications that we give them, when they respond differently to disease processes, that will all stick. My board pearl over here is just that isolated hypertension, super common, really hard to treat. That's going to be common because of the way their vessels get stiffer. Their systolic blood pressure goes up more than their diastolic. And so with that, usually they're going to need to be on more than one medication. And that doesn't need to feel abnormal to you. That is super common in treatment. Now with their lungs and their neurology changes, what you need to know here is that their lungs change a little bit with their lung elasticity. So they breathe out slower. Their lungs just don't adjust to changes as well. So when they exercise, they breathe a little bit harder, a little bit faster. Neurologic changes is my big one I like to hit on because mild memory decline is normal. It's normal, just like a car. As a car gets older, it can still work. And my grandma always says she hates when I compare them to a car, but I think it's a really good analogy, guys. And so I stick with it. When a car gets older, it still is a car. It still works. It can get you from A to B. You know, the engine turns on, the AC can work, but it just maybe does all that a little bit slower. So maybe it's harder for the engine to warm up. It's harder for the AC to cool down. So they have slower recall, processing speed slow. That's normal. However, it's abnormal to get lost, to forget family members' names. All of that kind of stuff suggests more of a cognitive impairment than memory decline. So remember, slower recall is not the same as dementia, but it can progress to dementia. So it's something we watch very closely. Now, as we get into metabolic changes, kind of with the GI structure and kidney changes with our kidneys, I want you guys to know that GI motility and stomach acid decreases, which once again, that's going to affect drug absorption and metabolism because your hepatic metabolism slows, so drugs stay in longer. GI motility slows, so once again, drugs stay in the system longer. But also that decreased stomach acid means it takes longer for drugs to onset as well. I like to think of that stomach acid, it's a thing that breaks down the medicine so that drugs can be absorbed and work. While if they have less of that, it doesn't work as well. Renal changes, really important to touch on, is that their GFR drops 8 milliliters a minute every decade after 40. That is an assumed change. We know that as the kidneys get older, they don't work as well. However, you know, you look at a GFR that's in the 20s, that's kidney failure. That's something different than just aging changes. But if when you're treating an older adult who's healthy and you see a lower GFR than they had 10 years ago, you would know, hey, that's kind of expected. Is it in that 8 to 10 milliliters? That's what we would expect. And so with that, we need to be careful on their kidneys. That includes the tests that we're doing, you know, because creatine can lie because their muscle mass is down, and that's you find creatinine in skeletal muscle. So it can kind of change what it looks like. A low creatinine with low muscle mass can mask kidney disease. So that's why every time we're checking that level, we order an estimated glomerular filtration rate, an EGFR, because that's going to be a way more accurate number. Sensory changes. Have you ever tried to talk to a patient when they're half asleep, half deaf? That's kind of geriatrics for you a little bit. And so the important thing is that differentiating between what is abnormal and what is normal there. Guys, literally, I've been saying this for the last 3 webinars. I was going to fix this. Presbycusis is high frequency hearing loss, and presbyopia is difficulty focusing on your object. So this is backwards. It's on my to-do list and I just keep forgetting. I'm sorry, guys. I remember this because presby meaning older, like, that's how I know, oh, this is an old person problem. And then opia meaning eyesight and cusis meaning hearing. So that's kind of how I know which one is which, because those can get easily mixed up in your mind. So just remember that. Nerve conduction's a little slower, so they're slower to respond and stuff. It's why we need to be really important with individuals that are older, but then also have neuropathy in their feet because their reaction to sensation is just a lot slower. And with that half asleep aspect, we want to make sure these things are normal, that they have earlier sleep and awake times, their REM cycle changes, but insomnia is not normal. And so you need to know that for your boards, is that an older adult that is constantly awake, can't fall asleep, that's not a normal age change. A normal age change would be, they wake up at 6 a.m. now instead of 8. Not being able to fall asleep for 6 hours while laying in bed, that's abnormal. So you need to be able to differentiate those two. Okay, now into pharmacology and polypharmacy. This is important. So polypharmacy is what I like to call the geriatric bingo game. How many meds can one patient be on? It's really, really common. It's the vast majority of the population actually in the United States, outside of just geriatrics, is on polypharmacy. And what polypharmacy is it's at 5 meds or more. And that includes over-the-counter and herbal supplements. And so the best way to figure out how many meds your older adult is on is the brown bag method, which is you have them come in to the office with their brown bag of meds. I tell them just scrape everything off your counter into a bag. That includes supplements, over-the-counter stuff. A lot of people don't think of those as drugs. They're like, oh, my magnesium supplement, I bought that at the grocery store. That's not a drug. But it is, and it counts towards polypharmacy. And because we know that their metabolism slows and their renal function slows, we know that that's going to mean slower metabolism of medication, which increases the risk for drug reactions. That little formula, if you can screenshot that and memorize that for polypharmacy, that's pretty much everything you need to know. So if you understand this concept right here, you'll know the importance of starting low and going slow. For every drug you give an older adult, I highlighted here BP and thyroid meds, but really I'm talking every single drug that an older adult is on. We want to start low and go slow. We do everything slower because of that risk of drug effects and risk of drug interactions. Next, I included here the AGS Beers criteria for you. This is a love of mine. I love the Beers criteria. I included here a QR code for the app. I think this might be to the Apple app, but if you go to Google Play as well and you look that up, you can download that app as well. I think it may cost maybe $5 for like a lifetime membership. I would highly recommend, if you have just that little bit of money to spare, you're going to want to sign up for this. This is one of my most used apps on my phone. I actually have a folder that I use. It's called my medical folder that I use almost with every single patient. I've got my UpToDate in there, my US Preventative Task Force, and this app, the Beers criteria, is in there just because the Beers criteria is a bajillion pages long. And so it is really easy to get lost in it and feel like then it's overwhelming and I don't want to use it. And there's a reason we made Beers criteria. It goes through drugs that should be avoided in older adults, drugs that for sure should be avoided in other adults, and drugs that are safe for them. Because drugs that we used to use all the time, like NSAIDs is a really good example. Ibuprofen, I take ibuprofen all the time. Well, in older adults, we really should avoid those, they say. They say that all chronic NSAID use should be avoided entirely because it's unsafe due to the increased risk of GI bleeding and kidney injury in older adults. So they say if you have to use an NSAID, you want to co-prescribe it with a PPI. That's really important information to know when you're taking care of an older adult patient. So I really can't stress enough the importance of having an app like this on your phone and leveraging technology in that regard. Okay, last thing here with polypharmacy is deprescribing. And deprescribing is this idea that we as practitioners want to take away meds that a client's on rather than add to it. And I know that really oversimplifies the issue because a lot of times medications are really good. They save clients, they change people's lives. But sometimes we're treating symptoms of an issue that is caused by one medication. That's what we call the prescription cascade, or that idea of a pill for every ill, rather than actually treating an underlying cause of an issue. The best example I have for that is ACE inhibitors cause a dry cough. Everyone knows that. It's like the number one testable thing is symptom of ACE inhibitors is a benign dry cough. Well, your patient comes in, they're got this dry cough that they've just complaining of. I've got this cough, it's annoying. Well, now we put them on Tessalon pearls because we say, oh, they've got a cough. They need a medicine for cough syrup. Well, then those Tessalon pearls cause dry mouth and they can be a little sedating. They can cause urinary retention. Well, now they've got these issues. So then we put them on a different medication. The issue here was that they were on a medication that we know causes a dry cough. We could have switched them to an ARB rather than an ACE inhibitor, or maybe a beta blocker is a better idea for them, or a calcium channel blocker, rather than treating symptoms with additional medications. So what you need to do at every single visit with an older adult patient is sit down, complete a med review, do that brown bag method, go through every drug they have, and then taper or discontinue any meds that you think are unnecessary. I often like to do this one by one, and then I'll schedule another visit in a couple weeks to check in on them and maybe discontinue another meds. It can be a real shock to their system just having like all the meds discontinued at once. But you want to maybe look at what we can stop and what non-drug therapies we could use instead. So here's a case study to give you guys a little test here. An 80-year-old female presents to the clinic with complaints of chronic dizziness. So we do a med rec, just like we're supposed to, and we see that she has long-term use of alprazolam for situational anxiety. So what are you guys going to do next? All we know now is that she's got chronic dizziness and she's on alprazolam. So what are your guys' ideas here for continuing on? I'll give you guys just a couple more seconds for people that have to hop back over to the Slido to answer, but these are really great answers. I especially love this review, all her meds. I have not seen this one before when I asked this question. Tapering off, of course, is the first thing that jumps into my mind as a practitioner is that, hey, she's on a benzodiazepine. We know that those, according to Bureau's criteria, are not really appropriate for older adults. And so maybe that's something we want to taper her off of. So important to look at. The other thing here, though, review her meds. That's a great idea because sometimes we immediately jump to one answer that maybe isn't the issue. Maybe it's the fact that she's on alprazolam and other medications as well that are contributing to the dizziness. So we want to look at everything first, and tapering off, of course, remember, we don't just immediately withdraw benzodiazepines, especially if it's been long-term use. So great answer, guys. Reduced dose, we do it actually 10 to 25% over 1 to 2 weeks. So every 2 weeks, you can go up to 25% of that taper until they're all the way off of it. If that's something you want to write down, that's kind of best evidence-based practice there for tapering. And then don't forget, when a new symptom arises in an older adult, the first thing I think of is a medication side effect. So acute confusion, I'm thinking, what drug could they be on that is causing confusion, rather than just jumping right into, oh, it's a brain tumor for sure. She's dizzy because she's got a brain tumor. So always jump to medication side effect first. That is a pretty safe bet. And then quick little break for you guys, because I know that was a lot of information and polypharmacy is very important. I just want to talk real quick about what Archer Review offers for you guys, as we're about a little less than halfway through our webinar. We are an affordable resource. That has always been our goal. We were all nurses and now we're nurse practitioners. Everyone that helps make the content for you guys is a nurse practitioner. We're not AI robots. We're not people off the street that have no nursing degrees using AI. We are nurse practitioners. And so with that, we want you guys to have a Q bank that makes sense and gives rationales, and on-demand videos that are short and break down content in an easy, digestible way. 3-day live reviews, clinical skills. All of this is really important to us. Clinical skills is something we recently just added. We recorded over 200 clinical skill videos. I show you guys how to suture. I show you guys how to do the Weber and Renee test. All these skills that are best not just explained verbally, but shown in an actual video in a hospital setting, we have professionally recorded for you guys. So you can use the links there to sign up. You don't want to miss any of this stuff. Right now, we don't have a trial for the QBank, but we have a trial demo, which I prefer. Rather than just giving you guys a look at a couple of the questions, you guys can actually see full demos of how the site works to see if it's a good fit for you. And then on here, if you guys sign up here with our TikTok, our LinkedIn, our Facebook, our Instagram, we are constantly uploading new content, reference guides, cheat sheets, webinar content links so that you guys don't ever miss anything. You're going to want to sign up there. And then over here is our email. nursepractitionerartreview.com comes to me personally. So if you guys have any questions, anything that you guys need help on, if you just need someone to pep talk you or anything, feel free to email this email and I will get back to you as quickly as possible. Okay. Now moving on to cognitive mental health. Look, I put my little board prep gold because if you don't know how to differentiate dementia, delirium, and depression, in the next couple minutes, you are going to learn because this is high yield. Expect multiple exam questions is more my opinion. I just think that it's highly testable, but I mean, I'm not making any promises to you guys. I'm not saying, don't come at me and say, Annie, you told me I was going to get 5 questions and I only got 2 questions on my board about this. But it's highly testable. It's easy to switch up. And so with that, I want you guys to know this information. Quick pop quiz time now. Do you guys have any guesses for, oh, darn it. Ignore that, guys. That's the wrong pop quiz. We'll just jump right into dementia. It was supposed to be the most common cause of dementia, which I think is actually in here if I switch to this one. There we go. Okay, back to Slido real quick, guys. What is the most common cause of dementia? Who knows the right answer to that? Alzheimer's disease. I like it abbreviated AD because I don't know how to spell Alzheimer's. I barely know how to pronounce it. The big A. I love it, guys. That is 100% right. I think I kind of gave it away because I jumped to the next slide too soon. But yes, 100%. There are a lot of different types of dementia. We'll cover some of the most common, but Alzheimer's disease is the most common. And the thing you need to understand about dementia that separates it just from cognitive, like, slowing, which we know is normal, is that it's chronic. So you have to think chronic and progressive. Those are the 2 words I want you to associate when you think of dementia, is that it says chronic progressive. They are constantly getting worse, decline that affects their daily function. And that's a really big important part here too, is that it's not just their it's inconvenient a little bit. It affects their daily function. And as it gets worse, it continues to affect more and more daily function to the point where they can't eat or dress themselves. And so in early Alzheimer's disease, you're going to see more short-term memory loss, but they can still have that social functioning. They can interact with family members. But in those advanced diseases, that's when they wander, they get lost, they have a hard time eating, they lose weight. This would be something I recommend screenshotting as those 5 A's, the amnesia, aphasia, apraxia, agnosia, anomia. It sounds a little bit like poetry slam. And so that's why I think it's important to remember, is because people do like to test, or even just in your documentation in the clinic, on what these different A's mean. And since they're so similar, like apraxia and aphasia, those sound almost the same. So anomia, amnesia, like I'm saying the same word nearly. And so it's important that you memorize what the difference between these words is and what they indicate so that you can chart correctly and you won't get tripped up on any board questions that may ask about that. Moving on to other types of dementia, these are the lesser known types, but still very testable and definitely seen in clinic very frequently, and they're actually kind of all on the rise. Vascular dementia, of course, is just like it sounds, vascular issues. So that's going to be more strokes, issues, TIAs, and they're going to have more neurologic symptoms. So cognitive issues for sure, but also a lot of neurologic issues. Of course, treating that, we're going to focus on stroke prevention, whereas Lewy body dementia is Parkinson's. It's associated with Parkinson's. And the big thing you guys need to remember there is early vivid hallucinations. So with Lewy body dementia, the thing that kind of differentiates it from Alzheimer's or vascular dementia is that they're going to have these visual hallucinations really early on in the disease. And then lastly, you have that frontotemporal dementia, which is going to be diagnostic by personality changes. So that's going to be where all of a sudden grandma's 65, it's usually young onset. So maybe like your dad who's 50, all of a sudden dad's always been really sweet, really gentle. He's cursing up a storm, really aggressive, gets physical. And you're just like, whoa, this is a 180 turn in my parent. This is not the parent I knew or grew up with. They may be thinking something like frontotemporal dementia, because that frontotemporal, that's our decision-making capacity, a lot of our personalities in there. So that's all stuff to look at. And I would be remiss if I didn't mention mild cognitive impairment as a type of dementia. That's going to be that stuff at the beginning that isn't as worrisome to you, but it does decline pretty fast. 10 to 15% of people with MCI progress to dementia. So that's when we monitor it. We perform yearly tests to see if they're getting worse. And of course, cognitive engagement, I always say use it or lose it. So if they're not using their brain, it's going to get worse. That's just the reality of it. Treatment, there's really no treatment, no cure, I should say, for dementia, for any of those types of dementia, but medicine's coming really far. We have found out a lot of ways to slow it down. Right now, our best treatment for Alzheimer's disease are those cholinesterase inhibitors like donepezil. We start that early on, and then when that stops working or the dementia is still getting worse, we put them on memantine as well. So that's more for those moderate advanced stages. And then just a big no-no is anticholinergics in patients with dementia. It just makes everything worse. So while we treat some things like Parkinson's disease with anticholinergics, we definitely avoid it in things with dementia. And then education is really important. I like to always emphasize this for family nurse practitioners. I mean, just APRNs in general. I think it's one of the things that differentiates us from a DO or an MD is we really prioritize that education because of our nursing background. You want to make sure that you're sitting them down and making sure that we've talked about, are they still driving? Is it safe for them to be driving? Do they have end of life documents yet? We want to make sure that those are in order while they're still mentally and cognitively there. Earlier those discussions happen, the better. Now, moving on to Parkinson's disease. PD is a movement disorder, so it is caused by a degeneration in the dopamine producing neurons. And as that continues to degenerate, it's chronic and progressive, just like dementia. They start to have more and more symptoms like tremors at rest, that slow movement. You'll see that Parkinson's gait where they're hunched over and they shuffle their feet, they don't pick them up. That's one of the highest diagnostic ones for me. Also, mask-like facial expression sounds kind of weird, but that is one that I will have patients bring in their loved one for fairly frequently, where they just show up and um, that's like what they say. They say, he just doesn't, he seems so out of it now. He seems so uninterested in everything. Like he just doesn't move his face. And that's what kind of trigger for me thinking Parkinson's disease. We treat Parkinson's disease with anticholinergics, like I said, which feels a little backwards. It does still have those same symptoms, but they've kind of decided that the benefit of those kind of outweighs the risk. Levodopa, though, and dopamine agonists like ropinirole are going to be the two drugs that you kind of need to know. Like, I want you guys to see that drug and think, ooh, that's Parkinson's disease. Okay, what's the most common cause of delirium in an older adult? Does anyone know that one? Or wants to just throw out a guess if they're on their Slido app pretty quick? We'll keep moving fast, but I'll let a couple people just submit their answers if they want to. Yep, great answers, guys. UTIs, infections, UTI again, organisms. 100%. It actually, if we're getting into the specifics of it, the most common cause of delirium is actually infection. So that is a UTI is an infection. I mostly see UTIs, but pneumonias also very commonly can cause that delirium. And the thing you guys need to know about delirium that differs from dementia, because they're very frequently tested and very easy to mix up, especially, I mean, of course, they would pick two words that sound just like each other to differentiate very different things, is delirium is acute and fluctuating. So remember, chronic and progressive for dementia and acute and fluctuating for delirium. Delirium comes on quick and it can totally treatable. There's always an underlying cause that we can treat and send them back to normal. So my tip for you guys here would be that if you ever get an older adult patient that has an acute status change, you should assume that that is delirium until you prove it otherwise. So you should always search for a cause first, saying, okay, this could be a drug they're on, this could be an infection they're having, are they under withdrawal, are their electrolytes off, their glucose off? Look at that first before you jump to something psychiatric. With delirium, the way we treat it is, of course, we treat that underlying cause. So we want to get them on antibiotics if it's an infection. We want to give them fluids or insulin if it's a glucose issue. That's going to be the first thing, of course. And then also that supportive care is really important. We want to reorient them, make sure rooms are well lit, that they're sleeping well, they're hydrated. In a primary care setting, if you guys are FNP students, the most important thing is going to be prevention. So of course we'll treat delirium, but a lot of delirium actually occurs in a hospital setting or in an acute care setting. So definitely know how you would treat it. You'd put them on antibiotics. But if we're worried about safety, we're going to refer them out or send them to emergency services. So from a primary standpoint, your most important thing is that prevention. We want to look at identifying them. So are we screening people that have dementia, have hearing issues, are in the ICU, and then using non-pharmacologic measures that may help reduce that risk early on. And with all this cognitive screening, especially with the dementias we were talking about, I wanted to give you guys this quick little chart to screenshot for cognitive screening tests. So, what tests do we use? There's a bajillion of them. These are literally just 5 of the most used ones. I pretty much use MOCA and MMSE exclusively for people that I know have cognitive issues or that someone comes in and I'm like, yeah, we're looking at dementia. It's progressed pretty far at this point. I love to start with a mini cog or a slums test. Those are really quick screenings and good for early issues. They're a little bit more sensitive and they give me a really good baseline. So even my older adult patients who their spouse isn't complaining about the fact that they're wandering, getting lost in their neighborhood, it's a really good way to say, okay, let's get a baseline number now. And then next time you come in next year, we'll do the same test again and we'll see if there's any change. Maybe your cognition's gone up because you've done a lot of cognitive exercises. Maybe it's really gotten a lot worse. I love having a baseline number, so don't underestimate the use of these tests early on. Depression, this is going to be the last cognitive thing we talk about. I really like touching on this one because it is super, super underdiagnosed. Um, in fact, older men whose spouse has passed, they're the highest risk of suicide in any population. So white older men who have recently lost a spouse, that is like burm, burm, burm. All the dingers are going off that I need to be doing screening for depression and suicidal ideation. They're very high risk for suicide. It may be generational, they think, maybe that they grew up in a generation that um like at that age they have more access to guns, things like that. But also it could just be they feel like there's no quality of life left. And so for me, one of the things that is really early on is that apathy. That's what I'll see. They present a little differently. So than a normal adult, they tend to present more somatically. So like they sleep a lot, their appetite's down, rather than a teenager who often comes in and says like, hey, I don't want to be alive anymore, or I'm sad all the time. A lot of the times an older adult will say, I don't feel sad. I just don't want to eat. I'm not sleeping well. And for me, those are big indicators of depression. So screening, there's a couple different types of screening. PHQ is what they use in Utah the most. So that's what I'm most common with. They'll start with the PHQ2, which is just asking 2 questions. And then if they answer yes to either of those questions, they then give them the full PHQ9. But the geriatric depression scale, I really like from a geriatric standpoint, since that's what my background is because it looks more for those atypical symptoms. That stuff that they present a little differently with, because it's a screening tool specific for older adults. Addition to that, I want to talk about anxiety. Often in older adults, that presents usually as an excessive worry. So about their health, about death of their family members, finances. They won't describe it as being anxious, but they'll ask you a lot of questions about it. They'll feel really worried about it. It keeps them up at night. That's a good indication to me that maybe they have some anxiety that we could treat. And as far as treatments go, because we know that older adults are so sensitive to medications, there are some pretty strong guidelines and recommendations for how we treat it. SSRIs are first line, specifically sertraline and escitalopram, just because those are the ones that have the least side effects in older adults. So, of course, with depression meds, I always say it's not a one shoe fits all. I tend to like to ask them, hey, do you have any family members, kids, siblings, parents that have been on depression meds? What worked for them? It gives me a good starting point, but I do like to recommend sertraline and escitalopram first just because of those side effects. We really do avoid TCAs. Those are like third line at this point just because of the fall risk, anticholinergic effect, high suicide risk. We really just try to avoid TCAs. Remember, as APRNs, we always consider non-pharmacologic methods as well. So that CBT, social engagement, those are really important in addition to meds. And also just remember, those meds take a long time. So, 6 to 8 weeks for effect to kick in. I don't want them to feel like, hey, this didn't work for me. I need something else. If after a couple weeks, they still need help. Anxiety is a little harder to treat. We tend to actually treat anxiety with the same thing as depression. That's something to explain to your patients if they come in and they're like, "Hey, I that's a med for depression. I'm not depressed." They actually work on the same receptors, and anxiety and depression are very linked in that regard. So SSRI is a great option. Buspirone is a really good option that's non-sedating if they just have generalized anxiety disorder and an SSRI is not enough. Okay, guys. Deep breath. That was a lot of information for you guys. Moving on to our next section, falls, mobility, and bone health. I kind of want to jump into that. So talking about falls, falls are a little bit like toddlers, because they happen all the time and they come out of nowhere and they just can cause major chaos. So it's kind of funny that we start young and we have all these problems and then we hit our peak of health. We're old, we're grown up, we can take care of things on ourselves, and then all of a sudden we're older again and we almost kind of have some of these same problems that we had when we were kids. They are the number one cause of injury and hospitalization in older adults. So I know a lot of people tend to guess that that's things like delirium, UTIs, infection, or chronic health problems like heart failure, but no, it's actually falls. And so you always have to ask every single older adult patient that you are caring for, have you fallen in the last year? And if they say yes, you want to do a get up and go test. That's a test where you have them sit in a chair, stand up, walk 10 feet, turn around, walk back to the chair, and sit down. What you're doing during that is you're timing them to see how long it takes them to do that. Anything longer than 12 seconds, we say high fall risk. That should be setting off alarm bells in your head. Hey, they're high fall risk. The thing about asking that question, though, have you fallen in the last year, is that literally 10 times out of 10, my patient is going to tell me, no, they have not fallen in the last year, when I know for 100% that they have. And so I always, especially since I'm a little younger than a lot of the older adult patients I treat, I'll say, hey, I just walked into a door at Lake Powell. Like, it happens to anyone. It's super normal. Because I think a lot of older adults are scared of aging and embarrassed about aging, about having falls. And so that's a really good way, I think, to build that trust between you and your patient and say, hey, here's like, it can be normal. But with that, then of course, you're going to want to check all those other things. You've got a high fall risk. That's when you want to start checking their blood pressure, especially orthostatic. You want to be checking their vision exam, what's their gait and balance, all that kind of stuff. For prevention for falls, the most important thing to see here is that the US Preventative Service Task Force actually recommends strength and balance training for every single older adult, regardless of fall risk, that's 65 and older. So I always tell them, hey, going to the gym 2 days a week or doing something that is builds strength and balance. Tai Chi is amazing for that. Weights are great for that. That's going to really help them keep their balance. And then, of course, changing things around their house that are going to help, like removing their rugs, grab bars, etc. Orthostatic hypotension, we know, is one of the major causes here of falls in older adults, because we know that their heart changes. That reflex blood pressure. So, I mean, I'm sitting right now, so my blood is pooling. My heart knows how much it has to pump to get it up to my brain, how much it has to pump to get it down to my toes. When I stand up all of a sudden, that number changes, and my heart has to quick reflex change its pressure and how much it's pumping. In older adults, that reflex is slower, and so they are a lot more commonly going to lose control of that blood pressure. Boom, all of a sudden they have dizziness, falls, they may even faint. So best way to fix that, hydration, letting them know they need to rise slowly, and maybe at this older age, we need to switch their blood pressure meds. So a lot of older adults have been on blood pressure meds since their 40s or whatever, so it's 30 years later. Maybe that same blood pressure regimen is too much now, and we maybe are fine with them being in the 130, 140 range if they're not falling as much. I'm a lot looser on my blood pressure guidelines as adults get older than I am at a younger age. So that's all stuff to look at. As we move into bone health, preventing falls is one of the best ways to help with bone health. But osteoporosis is really sneaky. That's when the bones look really fine on the outside. I mean, they're standing up, they look normal. But inside, if you took their bone under a microscope, you would see it's in this crumbling state, kind of like a stale croissant, if you've ever left a croissant out. Like, it just is flaky. They have these really porous holes in their bones, which that's how I kind of remember this. You look at osteoporosis. So osteo meaning bone and porosis meaning they have really pory bones. That's the easiest way I remember that one. The other thing to look at there is osteopenia. which is just a little bit of osteoporosis. So you've got normal bone density, which we measure with a T-score, that's done by like a DEXA scan, would be that +1 to -1. Osteopenia is that middle range when you start looking at the -1 to -2.5. And then once they hit 2.5, you immediate diagnosis of osteoporosis. And we catch that because we do DEXA scans. It's recommended that we screen every woman starting at 65. So we screen all women 65 every 1 to 2 years, do that DEXA scan. That's going to give us that T score, or a FRAC score is another word, something different, kind of the same thing, their risk of breaking a hip in the next 10 years. Um, and then we go earlier for women with risk factors. A good risk factor, for example, would be early menopause. So we say menopause, average age 51. If they had menopause at 40, they lost that estrogen that's really important for bone health at a young age. And so we want to screen them a little bit earlier because they're higher risk. Men, there's not a strong recommendation to screen every men, but men that have risk factors, so strong family history of bone disease, they don't do any weight bearing exercise, that would be when you want to screen men. Moving on to treatment, first line, of course, is going to be calcium and vitamin D, which I think everyone in their head thinks Fosamax. Bisphosphates are first line for osteoporosis. But actually, it's supplements, calcium and vitamin D. We only add bisphosphates like alendronate or Fosamax after, if their T score is really high, if the calcium and vitamin D weren't able to increase bone density, that's when I'm going to move them on to a stronger drug. We don't start with bisphosphonates because they actually have a lot of side effects. You have to sit upright after you take them. I mean, they're only taken once a week, which is really nice for an older adult patient. But when they take them, they still need to take them with a full glass of water, sit up for 30 minutes. They're really irritating to the esophagus, so you can get esophagitis. That's why you only take them first thing in the morning when their stomach's empty, when they're sitting up. That's all really important to remember. But just know that we start usually conservatively with calcium and vitamin D because a lot less side effects for that. So start there and move on if you need to. Practice question for you guys real quick about this. Mrs. Jones, she's 73 years old. She's got a FRAC score of 10%, hip fracture 4% over the next 10 years. T scores at -2.8. So that number, -2.8, what is that? Is that normal T score, osteopenia, osteoporosis? Where's that fall? The nurse practitioner decides that we're going to prescribe Fosamax weekly. What statement indicates that they need more teaching? We'll jump over here into the Slido and I will give you guys just a couple seconds. We've got a lot more content to get through and only 15 more minutes, but I will give you guys just a second to answer in there. First answers in. Oh, we've got everyone is answering. I plan to take my medication at bedtime to reduce the chance of nausea. People agreeing with that? Speak now or forever hold your peace. I like it. Okay, let's see. Right answer is, of course, that taking it at bedtime. You want to take it on an empty stomach. Taking it at bedtime increases that risk of esophagitis because they're going to go lay down in bed. So if you take it at bedtime and then they go get in bed to sleep, they're going to be flat. So you want to take it first thing in the morning when you're sitting up. Great answers, guys. I'm a really good teacher. Skin changes. We're going to zoom out now and look at the skin's largest organ, the body's largest organ, which is actually the skin. Couple things here. We do know the skin changes, and some of these are benign, some of these are not benign. So I want you guys to know the terms so that when you spot them on an older adult, you know what it is. Lentinges, that's the first thing. These are the classic liver spots, you may have heard them called. And that's what my grandparents like to call them. They're these, flat brown spots on, like big freckles on older adults. Totally benign. You leave them alone unless your patient wants them lasered off. You can do cryotherapy or laser them off. But often there are just so many of them, just these brown spots. They're from sun exposure. So I always tell my patients if they don't like them and it bothers them, the best thing they can do is avoid further sun exposure. So wear their SPF. Stasis dermatitis, you're looking more at what I like to call cranky calves. That's going to be when their legs, they've got that thick skin, ulcers, varicose veins. Their skins just look really irritated. This one's often misdiagnosed as cellulitis. It's a better indicator really of underlying cardiac diseases that you may want to treat. But for the swelling, compression socks are really helpful. For treatment of the itchy skin, things like a topical steroid or an antihistamine are really normal. But you may want to get their heart looked at and see why they're stasis dermatitis. It's inflammation of the skin due to blood flow that is stuck there, stasis, meaning it's not moving. It gets stuck down in their feet, causing the swelling, and that irritates their skin. Couple things, actinic keratoses. I put this one in red. This is like a must know. Those are those rough, scaly, they're precancerous spots. So little flaky spots. Normally you're going to see them on highly sun exposed. I almost always see them on the face. In men, ears are really common, like especially if they're golfers and they like to wear hats a lot. They'll get them on the tops of their ears or the noses, forehead. They're just really rough, scaly, and they are a precursor to squamous cell carcinoma. So that SCC, so we want to definitely treat those. We treat them usually with that 5FU, that cream they put that makes their whole face peel off, very painful. Or cryotherapy is the big one that we use kind of. It's easiest to just like, if someone's got 10 spots, I'll just hit them with cryotherapy. When they've got like 50 spots, 5FU just gets rid of all of them at once. It's really easy. This is another one though where we tell our patients, SPF, that's your best friend, use it. It's cheaper than lasers, it's cheaper than, excisions, and it is a lot less painful than skin biopsy. So I like to really push on SPF use. Lastly, last skin change is that senile purpura, which are those dark purple bruises that older adults get. They look really dramatic. It's just because their skin is thin and their blood vessels are fragile, so they bruise a lot easier than a younger adult does. They heal over time. It's usually not abuse, so you don't need to panic. It's just aging vasculature. Of course, take that with a grain of salt. Any large issues or things that look like handprints, anything that is setting off alarm bells in your head, you may want to report or do some further investigation, maybe for elder abuse. But other than that, I just like to say, hey, it's just bruises, they'll heal. Now we're going to look at some geriatric syndromes. First one we're going to touch on is incontinence, because of course we know incontinence, huge risk of UTIs, very common in older adults, but not normal. So incontinence is when urine actually leaves the bladder involuntarily. So different than just feeling like they have to go. Incontinence is when they feel like they have to go and then they pee their pants. And I think a lot of women, especially older women, like to say like, oh yeah, it's like, I just peed my pants because I coughed. Like, just happens with aging. I had 4 kids. It's definitely a cause of incontinence, and it definitely is more common in older adults, but that should never be considered normal. It can be a huge source of embarrassment for our patients. It can help, it can make them feel like they're not in control of their bodies, they can't go out. And so we want to make sure that we're catching this and treating it. There's 3 main types of incontinence: urge, stress, and overflow. Urge is that overactive bladder when they just feel like they have to go. Stress is more that too much pressure. So that's going to be like if they tell you, oh yeah, like I pee when I'm laughing, stress incontinence. And then lastly, overflow. That's usually due to incomplete bladder emptying. So men that have really big prostates, they go use the bathroom, they feel like they used it. Then an hour later, they're peeing their pants because they didn't actually empty out their full bladder. So those are the 3 types to know. Urge is the most common, and that's usually caused by an overactive detrusor muscle. That's that muscle in our bladder that helps us expel urine. And then bladder sensitivity. Our bladder gets a lot more hyperactive as we get older. That is normal. And so those 2 factors combined, along with risk factors we know of like age, caffeine, alcohol use, obesity, constipation, all those contribute to urge incontinence. You're going to want to get a really good history, talk about voiding patterns, how often they go, how often it's occurring, if they have any bladder irritants that they're using, and look at it that way, because there's a lot of medications that we can use, but we really want to start with non-pharm issues first. Relaxation, bladder training is really important. I like to teach my patients like every time before you leave the house, pee. Even if you feel like you don't have to super go, empty that bladder so you don't have overflow. Things that are important there. And then if that's really not working, of course, quality of life is our number one. We really want to look at that as APRNs. And so if it's really affecting their life, that's when we're going to want to look at drugs like oxybutynin. The issue is those drugs are anticholinergics. So the issue is you get all those bad side effects of anticholinergics in older adults, can't see, can't spit, can't, all the bad side effects. But sometimes we say that, the benefits outweigh it. They don't have to, they're not wetting themselves in front of all their family members. So we do definitely use it. We just want to be careful. Chronic pain, this is super, super common in older adults. It's very complex. My rule number one for you would be to not reach for the opioids first. And then rule number two would be still don't reach for the opioids. First line treatment, we want to start really conservatively with medications if we're going to use them. There's a lot of additional therapies we can add that are really first line, like physical therapy, hot cold therapy, TENS units, that one that kind of shocks you, acupuncture, things like that. Those are all first line for us, really. But if we have to add a med, we start really conservatively. For osteoarthritis, for example, we start with Tylenol. And then if Tylenol really isn't doing it, because we know that Advil works a little bit better on joints, especially inflammatory conditions, we use it, but we prefer using topical because that keeps it a little bit more local. And remember, if we're putting them on an NSAID, we want it to be short period of time and put them on a PPI as well. Neuropathic pain is a lot harder to treat. We've gotten better at it in the last decade, but a lot of patients suffer from neuropathic pain that we just don't have medication to help with. Gabapentins are first line option, but it does cause sedation. So I recommend they take it at bedtime and know that it's really going to put them to sleep. TCAs are another option, but really we try to avoid those as much as possible. One of the best ways to prevent neuropathic pain is to get that Shingrix shot because that can help reduce that post-herpetic neuralgia that comes from getting cases of shingles. So if we can prevent shingles, we can help prevent some types of neuropathy. Also, like treating diabetes, it's another way to prevent neuropathy. And then lastly, opioids, that is our very, very last line. We use it for very severe acute pain. Or pain like at the very end of life. And even when we use it then, we try to use the lowest dose, shortest duration, and we always put them on a stool softener like Senna or PG, just because we don't want them to get constipated, because constipated patients do not forgive you. There's nothing worse than being really constipated. Sleep problems. One of our last ones we're going to look at today is insomnia. That does increase with age, but it's not normal. There's a lot of things that contribute to insomnia. A lot of the causes are reversible though, like pain, medications that they're on, stress, late night episodes of The Office, all of that we can treat if we step in. So of course our first line here is sleep hygiene. We want to start early, getting them on a sleep schedule, telling them to turn off blue light like TVs, telephones, an hour or two before bed, avoiding really long daytime naps. Naps in older adult populations end up sometimes being like 2 hours. That's way too long of a nap. Take a 20-minute or if you need during your episode of Jeopardy, but 2 hours is too long of sleep. If that still doesn't help, sleep is really important for cognitive function. So a lot of times we say, hey, a drug is important at this point because they're not getting sleep. We like to start with melatonin because it has the least side effects and is really effective. Trazodone is okay. Um, I really don't like trazodone, but if it's the only thing that's going to help your patient or if they're having some PTSD symptoms, it's often appropriate there. Just know that those sedative hypnotics like Ambien, those are last case. Those will, and on boards especially, I mean, in clinic they have their use for short-term issues, but on a board it is never going to be the answer. Expect non-pharm measures to always be the answer first. Nutrition and weight loss. Unintentional weight loss is always a red flag for me. If they say they've lost 10 pounds or more over the last 6 months, they weren't even trying to. That's a huge cause for concern. I'm going to want to be checking for depression, for cancer, maybe teeth issues. It's funny. I wouldn't have thought about that until I started treating older adult patients, but a lot of times their weight loss is due to it hurts to chew because their teeth hurt. So that's really important. And then, so we want to definitely screen for those difficulty chewing, things like that. And then oral supplementation is really important in older adults. Sometimes they're just not hungry. And so trying to get them in calorie dense foods like an Ensure is really important if their weight is a lot less than we want it to be. At the end of life, we can put them on things like antipsychotics, like mirtazapine. It actually stimulates the appetite and helps gain weight, if it's really bad and it's end of life stuff. Quick case study, an 80-year-old male presents to the clinic with complaints of a 15-pound unintentional weight loss. What is your next action? So we know he's lost 15 pounds, wasn't trying to. What do you think you're going to do as a clinician? Give you guys just a couple seconds to get some answers in there. Come on, guys. I know you have an idea of what you would do. You guys have been nurses for a while. Assess. You guys are such trained nurses. Always assess first. Assess depression. Love that. Any other ideas of other things you guys would do? Order labs. That's really great. You want to definitely, especially if they've been losing weight, we want to make sure their nutrients are at where they should be. So that's a great spot to jump to. I like that answer. Great idea, guys. Let's go back and see where we're at. Evaluate for depression. Loved that answer, guys. Evaluate for malignancies. Do they have any age-appropriate cancer screenings? Are they up to date? What were their previous colonoscopies? Review their dentition. We want to look at their teeth, see if they're not eating. And then labs may be indicated. You guys got a lot of those answers. I have one last little clinical pearl for you here before we end up this webinar. Frailty is a syndrome. It's often associated with this nutrition and weight loss issue. It's this combination of weakness, slowness, unintentional weight loss, and low activity. So it's just like a combination of all these things. And it actually is a geriatric syndrome. Like you can be diagnosed with frailty syndrome. The best way to manage it is you have to use a very gentle approach. We need to be able to recognize that they have it and say, what kind of small things can we change to get them a little bit stronger, a little bit moving more gaining a little bit of weight if they need to. We just need to be able to recognize it first, though, because treating it, there's a lot of things you can do, but only if you recognize it first. So, anytime you see on an exam someone who's described as thin, weak, or exhaustive, you need to be thinking, oof, that's frailty. Okay, guys, well, that is all of our time for today. I had a couple more things. I'll do another one of these webinars next month, and we can start with those things like macular degeneration and hearing changes if you guys need some help on that. But for now, I want to just end with a gentle approach to geriatrics. This is another thing that just really sums it up. I think this is a highly screenshotable, if that's even a word, slide here. I made this just because I think everything about geriatrics is the opposite from aggressive treatment. I mean, you could say geriatrics with cancer, things like that, but we're just talking geriatrics in a primary care setting. We treat very, very gently. It's about nuance, it's about compassion, and it's about asking what matters most to the patient, like what do we need to do to help them. So really the call to action here is that whether you're treating diabetes or hypertension or maybe even depression, I want you guys to step back, look at the issue overall, the quality of life, and go very slow and treat the person, not just protocol. A lot of things about geriatrics is we go off of what normal protocol is for older adults. Like we loosen up diabetic control. We say, hey, your A1C can be a little bit higher than it was when you were younger because we know the risk for hypoglycemia are higher and frailty, etc. So step back and treat the person. And I just want to end with a couple Q&As over here, guys, that really helped me. If you guys don't mind, just two quick questions to end. How confident do you guys feel now after this webinar? Did I make it worse for you? Are you feeling more anxious now? Are you feeling better? Where do you guys sit at with that? How are we feeling at the end of this webinar? Okay, a 9. We've moved from a 6 to a 9-ish. That makes me feel really good, guys. I am proud of that we are moving up a little bit. People are feeling confident. I know there's a lot more to learn. There's always more to learn about geriatrics, and I will give you guys a million more webinars so you feel comfortable, especially you guys that are practicing for end of tests. And then one last question. This one is really helpful because I take this right back and I create the webinars for the next month based off of this, what you guys asked for. Like we have a diabetes pharmacology webinar this month because last month you guys asked for a diabetes pharmacology webinar. So we really do take the content that you guys asked for and use it. So what would you guys like to see more of? Pediatrics, eye problems, webinars on drugs. I like it, guys. We've got a lot of good things in here. Okay. The big heavy hitters. I mean that makes sense to me. And we're working on releasing a lot of new content. I've been recording like crazy videos for you guys, making new webinars, making new slides for you guys to go in our on-demand lectures. I know that all these things are heavy hitters. Farm, women's health, cardio, respiratory, all stuff that people want and kind of need a little bit of assistance with. So, I will make sure that these get added onto the webinar thing so that you guys feel confident in these subjects. I mean, you're always going to see patients with cardio issues, with neuro issues, with that are on drugs. So I get all that you guys want all that stuff. I will make sure it's in there for you guys. Thank you so much for joining. I appreciate your guys' time. I know that being a nurse practitioner student and studying for boards, you do not have a lot of time. So thank you for joining me on this summer day from wherever you were in the world. It's good to see you guys.